Hey. Morning, how are you? That's why it's long. The minutes. We can't say much. We just take notes. Yeah, it's just. One of the three of you was the chair. Well,
Yes, it's actually. Yeah, yeah.
He's got John Williams and we'll start in a moment.
They reckon it's bad, it's not acceptable.
Yeah, we will. Don't worry. This is so this is, you know. Come on then, people, let's take our chairs. Yeah. Sorry, Patty. It is not on the screen, so they're not on these. It's okay. We can see them, but they can't see. Can you hear us? They should be.
That would be for the testing.
Yeah. I'm going up to Steve. Hello, I haven't met you before, Stephen. You can't hear us. No, they're not hearing us.
Well, you. They're saying the remote you can't hear us? I can hear it on here.
Tom, I wonder if you do me a thumbs up or down. Can you hear me, Tom? You can hear me, but Stephen can't. Ask Tracy, can you, I know I can't see you, Tracy, but can you say that you can hear me or not?
I can hear you.
Caroline, can you?
I can hear you.
Lovely. So Stephen, I think it might be your problem. Because the other people on remotely can hear the room.
I don't mind telling that. You ruined that. That could have gone on for hours.
I could have had an end this conversation with him. Someone chat box.
I will do that. Sign language.
Thanks, John.
Sorry. Yeah, you're quite right.
Yeah. He's got, there's some lot of things if it's for that. It's in sleeping, isn't it? I can't miss what we do, so Stephen's going to be so. Next time, hopefully he can hear them. I'm just doing some checking of the sound next, so hopefully you can hear the room. Good. It's going away and coming back. I think we will start though, so that we don't run too late. I don't comment on it, but we are trying. We had some feedback at a recent meeting about the sound quality in the room for those people joining remotely, and one of the particular comments was about this side of the room not being audible. So that's why I'm trying to make sure I speak up. It's not that I'm wanting to shout at everybody in the room. We have a new bit of kit, and evidently that's also camera kit that will track to whoever's speaking. So let's hit that with Tom's nodding. So that sounds like it's a positive.
It's much better, much better.
Perfect. So that's really good news. So if we can just get Stephen connected, or he can get connected, then that's really good. So hopefully that will solve the audio problem. John, thank you for taking that on board, and thank you for coming and sorting that out for us. That's absolutely brilliant. So, okay, let's start the meeting. I'm just going to say I'm Heidi Travis. I'm acting chair due to the fact that Alison has stepped away and not taken a second term. I've got some apologies for the room. So I've got Hader has sent apologies. Ganesh has sent apologies if you're here, and I don't think there's anyone else with apologies. So it's Sarah, our new Ned, has formally started but is unable to attend this meeting. So she has joined us at the beginning of the month. She will be at meetings going forward. Brilliant. If Steve was back on, I was going to introduce Steve, but I'll wait until he joins us. And then, so we have Stephen Beaumont, who is our interim chief nursing officer, joining us. And he was just having trouble with his own sound. So when he comes back on, we can introduce him, and he's back. Stephen, can you hear us now? No, clearly not. Someone better chat box him again before I go through the whole saga all over again. No, he's gone again. So we're going to carry on. Okay, lovely. So any declarations of interest? Any new interests?
I didn't register in the first public board since I've become the ICB's chief medical officer.
Yes.
I have that noted formally in the minutes, and I'm doing that part time for 6 months.
Any interest in relation to any items on the agenda? No. Register of interests for the board of directors is in the pack. I think that's just for noting. If I'm correct, can we? Yes. So any comments on that, or? I've got that now. I've got that in there. Yes.
Later on, this is just
Yeah,
a
that's right.
discussion.
This is
Thank
paper bits. Yeah, thank you very much. I know I've seen the paper. I think, hang on a minute, I've suddenly lost the paper. That's great. Excellent. So I think we've got quite a focused agenda today. Board wants to be able to spend enough time in our private session this afternoon, but also we've got some key items, but things that we think we want to make sure we have a good discussion, but we're going to try and keep the conversation moving forward through the matters that are coming to the table. I wonder if Stephen can hear us now. Oh, good. So welcome to you, Stephen. I've just said that you would be joining us as our new interim chief nursing officer, so welcome to the meeting. And I'm really pleased that you are able now to hear the room. I kept trying to talk to you and everybody thinks that's hilariously funny as they knew that you couldn't hear us. So welcome.
Yeah, thank you very much.
Do you know the exec team?
I do, yes.
I think as and when non-execs speak, it might be good if they introduce themselves. But I think we won't go around because it's such a big group. That might be a better way today. And then obviously we'll get to meet when you join on site. That would be brilliant. Lovely. So I think we're starting with Janet. Get your name right this time, Janet.
There we go.
With your patient story. So welcome.
I'm Janet, I'm later mentioned as. This is David's story, who I've supported here in Watford. Now, David is a local chap who always lived local. He was a carpenter in his life. He's got a lovely wife, Linda. He's got 2 children, 2 grandchildren, one of them there. In May 2022, he started getting investigated for dementia. In October, he was diagnosed with mixed dementia. Now, following year in 2023, he started showing behavioural problems, becoming aggressive at home, and the community was supporting with that. But unfortunately, during that time, he got admitted to hospital while they were dealing with that. And he had an infection. He went into a hyperactive delirium state. So that's where he'd become quite removed, quite sleepy, quite withdrawn. But wife was telling us that the behaviours had been escalating at home. that this wasn't normal David at the moment. So once that started to settle with delirium, the aggression came out that they'd been seeing at home. That's when it got referred to myself, and then I got involved. And we looked at, you know, the What Matters to Me booklet, not understanding what David's needs were, as well as giving open access to wife, who is really keen of being stayed with us, and she calmed the situation down quite significantly. But also during that time, we ended up having an EI, we ended up having security at times. So it really did escalate in that situation. We got mental health involved, we got antipsychotic meds prescribed, which they were trying to titrate in the community, and we got that resolved. So that admission happened, and he was then put onto e-care as having a diagnosis of dementia. So we had to do a little bit of work around identification of patients with dementia. On his more recent admission, he came in with the exact same problem, but because he was already identified on e-care, I was able to go in with support. The wife, Linda, had told me exactly the same story. Behaviours had started escalating again in the community. So then we got the mental health team involved straight away. It was a lot clearer picture of what we could do. So the board started all on board, consultant was on board, of what could happen once he comes out of this delirium. Actually, we can up these medications to help support him. And it did. We never needed any enhancements. There was no security needed. It all worked lovely, and he got sent home in a better state. But with that, that's a highlight from what Linda's wife, Linda and David's wife said. But it's just showing that the role, the dementia role in itself, helps with that continuity of care. So I think that's what we need to build on, is getting that continuity. We're now capturing 88.5% of patients with a diagnosis in hospital on e-care, which is massive improvement. We still need to work with the outer area diagnosis as a bit, and I think that's something quite bigger than a lot of things. And we have an average of 65 patients in the hospital a day with dementia. It's a bit higher today, actually, so it is growing. And then, so my role is predominantly to support patients and relatives when they come in, promoting dementia awareness. So understanding that in every aspect that we do in the hospital, we need to think of it with dementia twang. So if we're looking at estates, are we thinking about the colouring of what we're doing with those? Are we thinking about how we get relatives in? All those kind of aspects, we need to think about how we're supporting nutrition. I obviously do a lot on education, so we use the Pinch Me tool. Don't pinch people, but you know, it's an acronym to look at challenging behaviours, and FERA, which is a communication tool. Obviously making links with other world wider services, so we can work together in tandem and looking at the hospital environment. John's campaign was one of the projects that I started on last year, just to bring that back, because obviously over COVID it kind of went on the wayside, which is understandable. But we had to bring that back to play. Actually, we do welcome relatives in to support their loved ones, and it's really important that they can come in. If they're used to having a waft with their loved one, bring them on in. So we've relaunched that, and that seems to have gone down really well. And then just ongoing projects with myself is Tier 2 training, which is recommended by the Department of Health. So we're looking at that and how we can incorporate that. Further connections with the community, and leaflets to support within hospitals. I've done a lot around nutrition recently with finger food diets and stuff, but I'd like to get some leaflets to support relatives to understand how they're possible. And then strategies to support challenging behaviours whilst in hospitals. It is a strange environment for patients whilst they're here, and we're strangers, obviously. And then we're just doing a highlight week, because it's Dementia Awareness Week in May, so on Thursday. We've got 16 different stallholders that are coming in the market that will highlight all the dementia support that people have out there. So should hopefully open to public and staff, they can come and grab it, whatever information they so need. That's where we are. That's a little bit.
We've paid something we've paid for the Council of Governors, so we're hopefully not taking up loads of your time. Are there any questions?
So I've got two questions. The first one is just your assessment of where Milton Keynes as a place is in terms of the level of dementia support in the community the availability of respite, etc. And then the second one is, have you got any experience of patients with dementia being cared for by the virtual ward?
So the community, I think we still need to work on services quite a bit. Unfortunately, we still are getting patients in that are hitting crisis point in the community and coming into our hospital to gain that support. So I think we need to work on how that's going to be managed, especially with our growing population. I think that's the problem, is other cities have obviously got to that point way long ago, and we're in it really. So we need to develop our services from the young to the old and see how we can manage that. But the virtual ward, they've not used, I think they've used it a bit. I think we can utilise it much more. Yeah, we're starting on that a little, and they are really helpful when they do get a referral through. So
And just on the community services, your feeling is they don't exist, or they do exist and we don't know about them, understand we can't signpost them?
I think partially exist, but I think we need to grow on that. I think we need a larger amount more than anything. So there's good work out there. It's just needs to grow. So
Thank you very much. You've done some excellent work. It really is a positive thing to hear about this patient story. Could you just describe, I mean, I acknowledge it's a system-wide issue, isn't it, from the communities, but I think that's more of an ICS challenge there, which I think is appropriate. But internally for the hospital, how did you improve from, so you've got 1 day from 1 week to 1 day for the dementia nurse, from 2 days from 2 weeks, forgive me, to 2 days for the mental health liaison. How did that rapid change happen?
it was the fact that it came through on eCare. So doing that work with ED, frailty team, the doctors of saying if you put the diagnosis on the problems page and it pulls through into my list, I'm then able to capture who came in as a social admission or a behavioural issue. Then I can pinpoint to those patients quite quickly.
Yeah.
Obviously, I already know David, so it was quite quick to identify. Actually, he's one that I would have wanted to see.
So would you say it was mostly down to technology?
I think so. Yeah, I think pulling that through is helping me massively create who's going to be the priority for that day to see. So yeah, making that through. And obviously, once they've identified, people are aware of their diagnosis, then we can adapt our care. Whereas it's kind of on the wayside and people are guessworking, it's not great, is it?
This is building on what Mark was asking, really. 65, 70 patients a day in the hospital. You're good, but you're possibly not that good at getting around everybody. Well, is it driven through tech where you're saying, see these number of patients?
Yeah, so I'm looking at the admissions that have come through overnight and we're just thinking actually which ones are probably going to need the most help at that moment. Who's hit crisis point really and who needs that.
Ian, did you ask about the did you ask about the virtual ward because you're thinking that could be a preventative piece in that it would help people support them at home so they don't end up coming into hospital?
Yeah, so quite often people with even mild dementia when they come into hospital will get much worse.
Yeah.
And if it is possible and reasonable to keep people at home, then things do.
Hi Janet, Gary Marvin, NED. So my question kind of slightly builds on the theme around here, which is it's just following observation, 65 beds seems a lot. I hadn't quite realised that many beds would be occupied. That's quite a surprise to me. And presumably that's likely to grow. I mean, I don't know whether you're in a place where you think you're looking forward and seeing that. Has that?
Yeah.
Have you seen that grow?
We would definitely grow as Milton Keynes,
Right.
compared to our cities, but still a bit lower than them, compared to like Bedford and Luton and stuff. So we're only expected to grow, unfortunately.
So significantly more beds occupied.
Yeah, and I think usually it's the patients that have had behavioural issues that are the ones that are usually a bit harder to get back out into the community. So I think that's the work we need to do, mental health of how do we manage that going forward, because that, as we said, it's going to grow. So,
And the last question, which really is just education for me, is you hear a lot about new drugs. Is there anything on the horizon that's going to fundamentally make your life any easier?
they're doing a lot around Alzheimer's, not the other types of dementia as
Right.
such yet. So there's a lot of research projects going on with Alzheimer's and Oxford are playing quite a large part in that at the moment. We'll have to wait and see to see if that really does improve things. I mean, it slows things down, but
Yeah,
nothing's a gift.
yeah. Wow.
Any other questions?
Case and
Okay.
I'm just going to say, I think Littleton's has got a dementia strategy, hasn't it, in a city, which
Yes.
projects these very significant growths in the numbers of people living with dementia. And one of the pieces of work we're doing that's sort of links to Janet's really wonderful and very complex work that you do across the hospital is around how we support patients with dementia who are aggressive and violent, because we've obviously got incredible work around preventing and reducing violence in the organisation, and this is some of our most complex work around how we manage that growing group of patients and their behaviours. And as Janet referenced, the environment is really important, de-escalation skills are really important, training is really important. So it's a really significant area of work.
And just want to talk about John's campaign and in relation to having the family members come outside of the visiting hours. Is that already in place now? Is that something that you're working on?
No, it's already out there. We did adapt it. We did have it in place before COVID, but obviously COVID stopped it. So it was just kind of relaunching it to say this is okay to have this and people can come in. Obviously, we don't want 10 members of family at your bedside at a time. So normally one nominated person usually is best.
And have you seen an impact of that? Have you seen an impact of that on outcomes?
Definitely. There's been plenty of patients that have been supported by their loved ones out of hours, and it's made our lives easier because it's someone they know. The patient's life easier, the relative who feels more confident knowing their loved ones being cared for that they like. I just see it as a win-win all round. So I'm very open to John's campaign.
Thank you.
Well, thank you very much, Janet. As you can see, I think everyone's really very interested, but also very supportive of everything you're doing. So thank you for coming and talking to us today.
Thank you very much.
Very good. Okay, so I'll take the minutes as read. Have I got any comments for accuracy or on content of the minutes? Approving. I'm not seeing anything online from anyone else. Thank you very much. So the minutes are taken and accepted. There are two.
Sorry,
I'm so sorry.
there's just one thing. I know that Hader had a question about an outstanding bit, so
Okay.
just because I recognise he's not here today, I just don't want him to miss out. So maybe perhaps an action for you to
Pick up what he just.
someone's give you
Aware of that. He doesn't
check actions, but
Yeah, that's good. I'll find a way of bouncing it back, don't worry. So there were two actions, one of which is on, they're both on the agenda, I think, today. Yes, one was in the chief executive report and the other was the item. I think the item number might be wrong, it's on here that shows what it is, but they're both in the agenda. Yes, if you now see a puzzled face.
I'm not sure the maternity review is. This was the external review commissioned looking at the care of 6 ladies who'd been admitted to our ICU last year.
So what I've read then might not be then linked to the safety, so that's not on here, you don't think?
I don't think so.
Okay.
That report did go to the Quality and Clinical Risk Committee at the end of March.
Right.
I wasn't proposing to bring it forward, but I'm very happy to do so. We can send it around to members. It was generally speaking a positive report with there were no particular issues found with the care of women who went to ITU for level 2 care. The recommendations such they are around cell salvage, which is a mechanism used to reduce blood loss to allow blood recycled back to the patient in obstetrics, and in this case an options appraisal to adopt that technology.
I think there's something in the maternity patient survey interim report that I might have picked up, but was not the same thing, but that's perhaps what that is. Okay, and the other items we can more. Anything else on Matters Horizon that people wanted to? Lovely, thank you. Anything else? So I haven't got a lot. Just a few things. Obviously it's early doors in terms of only a week and a half ago. I think just as a point of practice, Kemi and I have talked about things like publication of papers and ensuring that they are out in good time for all members to be able to read and absorb what's in them. So we're talking about 5 working days as going to be the best practice. That is the aim. I think just to say to the board and Wise team that in the transition phase of acting chair, obviously there are some roles, chair roles of committees and other roles that need to be reallocated to other people for good governance. And we're also making sure that in the committee terms that we're then forward the next piece of work that we're doing, and we're actually talking about that in our private session this afternoon, and then that will be shared with board in a future meeting. I just wanted to say around that, one of the things we're trying to do is making sure that anything that we're doing in the short term, I mean the holding the tenure, is to make sure that we're trying to have those conversations about the long view with everything, so that we're not just on fixing things for a moment in time. So I think it's very clear the direction of travel for the hospital and the priorities. So I think that lets us make sure that the things we're putting in place will go forward when the chair comes into the full role. Another part that Kemi and I have been talking about comes partly from looking at the committees and the governance of the committees and policy, is we're also looking at the kind of framework and operating standards for us as a board and how we travel forward. And that's a piece of work I think particularly over the next couple of months we will see coming through. Just to let people know that early days, but I have spoken with the ICB, I have spoken with Region, very short conversations, but just even short term, I look forward to operating and working with the system, with the regional teams, and meetings are already in the diary for me to be able to do that. There are lots of meetings already in the diary, I've realised, but that's good. Here in Milton Keynes, we have organising a Govern Well session for non-executive directors and governors to come together and spend time really working through understanding how, as non-executive directors, we get assurance from our work inside the hospital and our meetings with the executive, and also to assure the governors on how they can be assured that the non-executives are doing their role and able to give the governors assurance. I think it's also, for me, from my perspective, part of the journey we want to go on of being a really united team and considering how we can function together at the very best to make sure we're discussing and talking about the people of Milton Keynes and wider, getting the very best care that they can get. So I think that's our plan. And one of the parts from that for me, and I actually haven't mentioned this to Joe, but I think it's something we've done before, but I think with board colleagues, I'd like us to establish some short board visits to site, or non-exec visits to site, and I think governors as well would be good. You can go 30 minutes to somewhere. I know people do that already individually, but I think that would be something really good to go out there, meet colleagues in the hospital, and John's going to say something in a moment. And we've done that before in various formats, buddy formats, working together, going and visiting with exec colleagues, and we obviously need to prepare for that. But I think it would be something good to do. John?
Just to say, if any member of the board has a few spare minutes after the board meeting, we could pop along to the new radiotherapy building,
Which looks most impressive. Very good. That's good. And I think on the agenda items, I've already said that I won't say they're standard items, but there are no, I don't think, significant items. Oh yes, but I've already mentioned Sarah in the apology at the start. So I think that's all that I've got from me. So I can take any questions if anybody has got any. Or I shall hand to Joe.
Thank you. First off, I want to acknowledge Alison's contribution to the hospital. Our name is earlier. Just a big thank you on behalf of everybody for all that she did in her tenure, and she will certainly be missed. And obviously welcoming Heidi as our new chair. And I think it's also worth saying that from an exec perspective, we're just looking, we've obviously got a new chief nurse coming in July time. We have Stephen here as the interim, and we're also looking at how we strengthen other exec roles across the portfolio. So keep board updated as we go through that. John's just mentioned the radiotherapy centre. Delighted that we have officially received that now. I think it's with ADMK as our subsidiary at the moment, but be good to get board members on for that if possible today. A couple of other things, if I may, before I hand over to Ian for the virtual awards piece. We've been doing a number of town halls across the organisation with staff on parking and the estate. As you are aware, he hesitates there because I think may not all of these things as part of the Oak Ward development and as part of the enabling works for the new hospital. We are building a multi-storey car park at the back of the urgent care centre, which on one hand is great, but in the interim, we lose the car parking outside of Oak House and we lose the ground floor car parking behind the urgent care centre. So clearly that will put a significant pressure into the system for about 12 months whilst we build the new multi-storey car park. So we have been engaging across the organisation for a number of weeks now, and the consultation process closes. It just closed. Excellent. So we'll be going through all of the thoughts, ideas that have been put forward on that, and we will come back to the board as soon as possible when we've got outcomes of that. Alongside that, we've also been doing a consultation around office space and how we continue to support all of our professional staff, so that the non-clinical hands-on staff, given that we are going to have to demolish the postgraduate centre as part of, again, enabling works for the new hospital. And so a number of ideas and ways of working have come forward as part of that consultation. All parts of developing the estate. Obviously, it does create change, and we just need to manage that and engage people as best as we possibly
Can I just ask on that? What's the timing that those buildings need to be emptied by? Should have asked them actually, maybe.
So over to you.
We are hoping to start the Oak House wards probably from about August. And similar sort of timings for the multi-storey car park at the back. So in some respects, that's a good month to start because there's lots of people on holiday, and so there's a sort of like gentle easing into the issues. But it is going to be with us for, as Joe said, for the best part of the year. And so we're going to have to have a multitude of solutions. There isn't a single solution to magically come up with additional cover.
And the office clearance.
So the office change in terms of closing the education centre, there's approximately, I lose track, but maybe 120 desks. So that is a very significant issue, and the reality is it will mean that non-patient facing roles that don't absolutely have to be on the site will have to either move to engage or to some sort of team hot desking, which dramatically reduces the number of desks on site.
And it was all the timing.
So we have to be out of that building by about January 26th, which sounds like a lot of time.
That's fine.
But-
So there's,
but it
yes,
is.
there's a timeliness to that. I wasn't sure if there was a real time pressure to it.
assume all other things being equal. Okay, can sorry, I want to bring Kate in to just update on the HSE and CPC, two major regulatory what's going on.
Okay, thank you. As the board knows, the health and safety exec came in and did an inspection in February, and we had two improvement notices that the board has seen previously in all of the packs. We had a compliance deadline of the 19th of April to go back with our assurance plan and action plans around those improvements. This pack will come back. It's just I'll bring an assurance pack back through the audit committee, the next audit committee, and then it's health and safety committee, which is on the 13th of May, detailing all of that. We've had some further dialogue from the HSC, who are really pleased with our progress, and they've asked for a couple of other bits of documentation, which we will send them, and all of that will then come back to the board. But the audit committee will be the responsible board committee for tracking progress. So that feels like there's a lot of work that needs to take place and continue to take place. We've got a new interim head of health and safety who joined the organisation about 2 weeks ago. And we're looking at some other posts as well to support the reduction in violence and aggression programme particularly, and also manual handling, which I suppose has already been appointed to. So work's progressing in that area, but good feedback from the HSC, which is helpful.
Andrea.
And then on the care quality, so the board will be aware we had an unannounced inspection in our emergency department, and we are now dealing with the data request, the information request that comes in following inspections. So that is due back with the CQC at the end of this week. So that we will then bring that again. We'll bring anything that we get formally back from the CQC back onto the boards as usual.
Just on that CQC, in case anybody has any questions. So two other things. One is we, as part of the informal feedback that we received on the day, where there were no significant or urgent interventions by the CQC, they did raise a number of other issues. But we subsequently wrote back to the CQC, challenging a number of their points in terms of the accuracy or indeed the appropriateness of what they were highlighting as issues. And we are in continual dialogue about the inspection itself, given its very targeted focus on the emergency department. And only this morning I've had another email about how we engage with the CQC leadership about this inspection. So it doesn't feel like it's been a routine unannounced inspection in the way that it was carried out, or indeed the volume of inspectors and the targeted nature of within ED. And therefore we want to continue with that dialogue with the CQC to ensure that we get the most appropriate result.
And it is part of the new style of inspection process, so it's very new for everybody. It's very new for the CQC and it's very new for us. So it's this new style of inspection which we're part of the first review. So there's a lot to learn first really to pass.
So just building on what Kate's just said, and I apologise if there's been a report somewhere that actually gives me this information, but I'd quite like to get a better understanding of what they did, what they looked at, how it worked, so I can just get a better understanding of what the lens of the CQC looks like and it's put on the hospital. I think that'd be good from a governance viewpoint.
Yeah, completely. There will be the formal report that comes through, and we will also ensure as part of that we give the board the sort of MKUH view of how the inspection went as well. Two other things, if I may, before I hand over to Ian. One is the staff awards shortlist has been announced. We've had almost 1,000 nominations received as part of those staff awards. That's the highest ever again, which is fantastic news. And then the second thing is that we are this year replacing Event in the Tent with the MKUH Expo. We have a 2-day event in July, and we've already got some excellent speakers lined up for that. So we will get those dates out to the board. Make sure if you can pop in at any point, that would be.
We have to ask, where is it?
Yeah.
Oh, in here.
It's not in the tent. No, we're in the tent. We're not that clever with our marketing. You're into the tent. No. Since we now reported to the board that we have taken over ownership of this building, we are able to run it. If I can then just ask Ian to come in on the virtual wards.
Okay, so I can't remember the exact genesis of wanting an update on virtual wards, but if I give people a bit of background about what the virtual ward is and does, and we can then possibly decide whether the board wants to hear more about it or possibly quality committee. So conceptually, a virtual ward is the idea of managing people who would otherwise need to be in hospital in their own place of residence. So that involves doctors, nurses, therapists, medicines, etc., that would normally be associated in hospital being delivered in people. Now, the term would need to be in hospital is really quite important here. Because we need to be in hospital and would be in hospital. So, for example, we have about 70 patients who don't meet the criteria to reside in hospital, i.e. could be looked after in a different environment. Those patients, if they end up in the virtual ward, in some ways that's good news, they're not in hospital anymore, they're back at home. Equally, that's not the core purpose of the virtual ward. If they don't need hospital healthcare, then virtual ward is appropriate. So there are lots of grey areas. Colleagues may remember the initial announcement about virtual wards from memory in the run-up to Christmas 22, when 5,000 or 10,000 additional beds were suddenly going to appear in the NHS. The vast majority of those. So the NHS England introduction of virtual wards inevitably led to some challenges, i.e. there was a need to hit targets around how many beds we had, rather than necessarily ground up developments of what would be solid. The funding for virtual wards was non-recurrent and uncertain at the start. The expectation in Milton Keynes from NHS England is we have 124 patients in a virtual ward. And the reason for that is based on the number of virtual beds per population. So there's a formula around the country. So the NHS England ask is 124. Milton Keynes as a place with the joint leadership team leading this has taken a slightly different approach. And we've really focused on 40 real virtual ward patients, i.e. what we're calling the hub patients. These are patients who we could all, if we were to meet them today, we could imagine that they would otherwise be in hospital, very much more dependent patients. We're a bit less concerned about this magic number of 124. There are inevitably other patients whose discharge from hospital may be accelerated slightly by the virtual ward, or indeed who may avoid admission to hospital and have enhanced community care, which is of a better quality, but not necessarily avoiding physical. We're sort of empowered to take a slightly different view here because from April, the funding for this was all going to come from essentially a grant held by the council rather than core NHS funding. So partners in Milton Keynes are very interested. The scale of the endeavour is significant, so it's 2.2 million quid of recurrent investment in this ward team. It's a whole-time equivalent of about 33 people working in the virtual. Now, in terms of whether we've got up to this number of 40 hub patients, we generally run in around sort of 15 mark, so we're not up at the 14. That's a concern. We're currently doing some work to try and understand exactly what is causing that. Is it due to staff availability? Is it that our staffing establishment, despite being 33 whole-time equivalents, isn't right for the case mix, or is it a failure to refer into the? So we're doing that work. It's being managed actively through what we call the Improving System Flow Steering Group, which is a sort of multi-agency group in Milton Keynes, which I was leading recently handed Internal Social Services. Obviously, Vicky Olner, who's now the medical director for Unplanned Care, leading that from the hospitals. Very happy to bring more detailed information, case studies and things possibly to the quality committee so that we can have discussions about that and understand the work of the virtual ward. But we're very much trying to increase the number of patients in it and importantly to demonstrate value for money. It's important we're handing up with the council.
Thank you. Excuse me. Thank you, Chair. So do you think, Ian, the 33 FTEs would be more or less if those patients were in this hospital?
So if there were 124 patients in the hospital today and they all left the hospital, we are using far more than 33 full-time equivalents to look after those patients. Jonathan may have another number in his mind, but for me, about 2.5 million would be about the running costs of a 28-bed ward. So if we were able to look after 40 patients in Freehold's done equivalent to 2.2 million. That would be good news. Problem is we're not.
So kind of building on that point, and sort of, I'm just to make sure I understand the genesis of this, the rationale for it is it is perceived to be a long-term solution and it's perceived to be value for money and good patient care, as opposed to a short-term solution to some immediate issue.
So with all these things, the implementation is inevitably challenging. And fundamentally, though, there are lots of patients, lots of people in our hospital who are patients who don't need to be. And clearly that's difficult for our efficiency, but more important than that is the deconditioning. So if we bring somebody who's relatively frail into our hospital, within 24 hours, they're losing muscle mass and their problems are essentially snowballing. So if we can avoid bringing these patients into hospital in the first place by improving community services and the acuity of patients that the community can look after with our help and support, that all works well. So intuitively, same day emergency care, the Maple Centre that we opened a couple of years ago, plus virtual ward, plus Milton Keynes and very rapidly growing elderly population, we should be able to deal with that through the. I'm confused if I didn't.
No, that's the key point. I was trying to get my head around the amount of money we're throwing at it and where we're throwing it and whether we had. I know you can't answer all these questions now because it's too big program. We're at 15 and it gets 40 or 50, but the belief is it's a good idea.
Yes.
Actually, Gary just ended on the line I was going to assert. Just to be clear, we do think this is a good thing. It seems to me a no-brainer that the system, not just this hospital, would welcome it. The devil's in the details.
Correct. If we can get the model right and can demonstrate that it represents value for money, absolutely. Those are the caveats. That's why we're working well together in improving system flow, steering room, to really kick the tires of the virtual ward as it develops, rather than just accept it's a good thing and it will suck up 2 or 3 minutes. So actually evaluating.
So could I just explore then briefly, as a system, is where the money comes from, because we're benefiting, but some others could argue they now have an additional cost because the individuals either staying at home, which has an impact on the council, or they're staying in a care home, has an impact on families and care homes. So as an ICS, where do you think we're at with?
So I'm not able or willing to answer on behalf of the ICS despite my dual roles. If you were to argue that the local authority should be upset by virtual ward because the patients are at home rather than hospital, that argument would finish quickly, because if we prevent deconditioning, the long-term costs of looking after those patients in the community reduce dramatically. It's very much in the council's interest for patients not to come into hospital and be deconditioned, and they very much get that. And that's why we're on the same page.
Therefore, they seem willing to share budgets.
Well, so the money we're currently spending is held by them as a grant, so it is council money. Now, as is often the way in the NHS, despite the difficult financing, there is again a specific line around virtual wards this year, which we found out about only about 3 weeks ago. So the virtual ward will probably be 50-50 funded this year. And in Milton Keynes council.
So I'm going to go to Gary, then Precious, and then I think we'll decide kind of where sort of there's clearly a lot of interest in this, but I think we need to.
Thank you. And I mean, obviously, there is an argument from a cost effectiveness and efficiency point of view for virtual wards, but from a clinical risk point of view, and yes, I understand that you said that obviously if someone is in hospital, they're deconditioned quickly and such. But are there other risks in terms of intervention and clinical care that would be different in terms of being in hospital versus virtual ward?
So there are, of course, additional and different risks. I think I would go back to the point that actually being in hospital is not a safe place to be for a frail patient, both in terms of the possibility of errors of omission or commission, but more importantly from that deconditioning perspective. So we often have this view that community ED and being admitted is a place of safety. Whether it is or not, I think is exploration for every patient.
Is there a wider criteria for who will be in the virtual ward versus the hospital, who stays in the hospital? Or is that still under?
So again, there are lots of criteria, but my slight concern would be those criteria are driven in part to be able to demonstrate this number of 124, which is the magic number contributing to the 7,000 or 8,000 beds that were offered nationally. From my perspective, from the council's perspective and the geriatricians, we need to be pragmatic. So if we can meet the needs of that patient, we should be looking after them in a virtual ward. We have discussions sometimes about virtual ward patients. What is the right rate of readmission to the hospital actually coming into the physical hospital? Should we see that as a failure or not? No, I don't think we should. If you told me that my mother, for example, if she went to the virtual ward, she had a 50% chance of needing to come into hospital. If it didn't go according to plan, I'd still take my chances, I think. So it's a really nuanced and interesting discussion.
So, possibly a couple of questions. First one is this reviewed through FIP or where is this looked at? Monitored?
So this is, so in terms of the investments and the KPIs and things, it's looked at the Improving System Flow Steering Group, which reports to the Joint Leadership Team. And because at present, the monies are essentially ring-fenced NHS and or council grants, that feels like the appropriate place to do it at present. Clearly in the long run.
Excuse my ignorance, so it doesn't happen within.
So I think she'll get, we have, the activities will be reported at Quality Committee.
So the money for virtual exam, in terms of who spends the money, clearly the community trust spends quite a lot of the money, the council spends some of it, we spend some of it. The government decided that virtual ward funding needed to come in through acute trusts, I think, to force collaboration. So the money does come through our accounts, but it's essential.
So my real question asked, where is it reviewed? Following question is that where do you decide whether if you press the go button and spend another 100 grand, it gets you 40 patients in 6 months? Who's making those decisions? And is it worthwhile, since you, Jonathan, looking at longer term, if I said to you, if you give Ian another 100 grand, we move this on? So it's not where those discussions are happening.
Those discussions are happening in place at the Joint Leadership Team, and there are additional monies potentially in the grant funding, which is allocated in the story.
Thanks.
I think my question may have been answered, but it's just a lot on the funding, but there's quite an impact in terms of inconsistency. The fact that before you mentioned that the funding will come from council. What mitigating factors are being put in, knowing that previously it's been quite inconsistent, and just listening to the conversations right now on funding and
so there's no easy answer to this. When the virtual ward beds were first announced, 100% of the funding was coming through the NHS, ring-fenced from national. And then the version was the second year, 50% funded through that ring-fence mechanism and matched funding for the other 50%. Now you can imagine partners looking at each other saying match funding from where, from the ICB, from providers, wasn't clear. And in Milton Keynes, what that has become is match funding from grant help, the grant held by the council. I think the Milton Keynes position had been until this year's funding was released or announced. The Milton Keynes position was that let's do this properly, let's be really clear about what we're after, i.e. these 40 acute heavy heart patients, so that we can evaluate this, because a year later it would have been arguably yes, to look at growth monies and to prioritise the virtual ward of other potential investments, but potentially to look internally for CNWL to look at themselves and the council as well, potentially to disinvest in other things in order to support the virtual ward.
Right.
But I don't have a straight answer to your question. That's the
I'm going to move this on. Your first question was really where this would report and what assurance or information the board.
Surprised by the level of interest.
So I think it might be good post for you to take this away and think about through, and to Gary's point in terms of the different reporting about where it would report. But I think clearly the board would be interested in an update. Probably not every month perhaps. So maybe that's something we can build into the plan.
Yeah, again, I'd just be clear, it's quite a small amount of money compared to what the trust is spending overall, so everyone's just spend lots of time on it, but agree.
That's what I think, it needs to be appropriate, and there's probably discussion at quality committee.
Okay.
Thank you very much. Very interesting.
That's it. So the report there from the ICS is.
Thank you, everyone. Okay, I shall move on to the serious incident.
Thank you. So this is item 8, a relatively short report. I think probably 3 or 4 things to highlight. First is the transition from the old style incident reporting investigation mechanisms to PSER. which has now happened. So it happened on the 1st of May. And essentially that is shifting towards an approach which very much values comprehensive daily triage of incidents that are reported. It gives us more choice about where we choose to invest our efforts in terms of investigation and evidence, and much more focus on learning and less arbitrary definitions of what an incident requires. So far, so good. It is brilliant trust fund. Obviously, report back on that regularly, and that format of this serious incident report and other quality measure reports will change as a result, as is highlighted in. There are 3 serious incidents referenced here, all of which occurred in February. A maternal death of a lady who had delivered and discharged, was known to mental health services, a death related, predominantly an issue with 13WL. Secondly, the death of a patient who had a fall on Ward 18 under a deprivation of liberty safeguard. Double reason there. Doing thirdly a gentamicin error without serious harm, but recognising that we have had gentamicin errors in the past which have caused serious harm, chosen to report that as a serious incident. Investigated. We will be reporting many less serious incidents. Then some inquests are mentioned in the report, and probably most importantly, some of the key messages or the nuggets of learning that have been identified through our incidents, shared through a variety of many bullet points in this report. I don't know if Kate wants to say anything else about reporting.
No, I highlighted a yellow box at the top just to say that this will be the last time the board receives a report like this. We're going to move to an integrated quality governance report so that we can strengthen our reporting in some of the areas that the board sees less often, so particularly around regulatory compliance, for example, and also so that we can look more effectively at thematic work so that we can cross the quality domains around shared themes and where we've got opportunities for learning that need to be brought on safety into audit, for example, and through to experience. And so it will be a very different report that comes to the July board.
Thank you very much. Maternity patient survey report.
Yeah, good morning, everybody. Can you hear me?
Yes, thank you.
Good. This is, as you know, maternity services have been highly inspected over following concerns in other trusts around England, and the CQC PICA survey is just another way of measuring our quality of services. As you can see, the main themes for me is about ladies being in pain, in labour and pain management, being left alone, not having input into decision making and support from midwives going forward. The unfortunate thing for me was we didn't show any positive things in there, so my next report will have positive things. So I think we need to, for me as a Chief Nursing Officer, we need to triangulate this with all the other reports we get in to drill down on themes and trends. So this is just one short report. The thing with the PICA service is we can't focus on who gave the information because it's anonymous and it might have been a one-off. So I think for me going forward, we need to have a triangulation with our complaints, our positive feedback, also the feedback from CQC inspections, and also from the inspections carried out by NHS England on our maternity services. So we're not looking at things in isolation, but more of a thematic review of how we're looking after our ladies, but more importantly, how we're supporting our staff on the maternity units. So a short report, but I think next time we need to look at thematics of the other reports as well, so we're addressing the issues.
Thank you, Stephen. Any questions here?
And so, Heidi, just by way of assurance in some ways, the maternity assurance group met last Thursday, so before Stephen joined us, and we went through this survey in a bit more depth. Stephen's absolutely right, there are lots of positives in it as well, and this cover page doesn't really that necessarily. I think at MAG, the maternity assurance group, our the key takeaway messages were around some elements of postnatal care, and also about breastfeeding. Those were the two things that we're very keen that the team develops a smart action plan quickly, and they are working.
Any other comments or questions? Even Joe?
I suppose one thing for me is that we normally bring patient survey feedback as a whole together through the board, be that our outpatient survey, inpatient maternity, whatever one it might be. So can I suggest that this gets wrapped into that piece of work, such that we get the key themes associated with all the different aspects of patient experience? I think this is helpful to inform that.
I think,
I
Stephen,
agree,
that picks up on your point of bringing it in the round, doesn't it, of set of feedback. So that's really helpful. Excellent, thank you very much. And we'll move on to the performance report. Emma, please. Thank you.
So dashboard on page 50 of the pack, to draw to the conclusion of the year. This is month 12, and we finished our UEC performance in month. The focus was in month in March on the 4-hour target and delivering 78.1%, which was above the threshold of 76 expected. The total year performance was 74.4% against that 76% expected, but in reality the focus was very much on the market. And we were still in the high end of the table in that delivery. I think just to point out the consistency of delivery over the year was very different to some people that achieved far higher than us, or marginally higher than us in March. Did make a significant change in improvement between January and March. Consistency has been there all about for the year. The UEC pathway obviously made up really two main components: the flow in the hospital, and as we've just been discussing about virtual ward, I think it's fair to draw attention to the non-criteria in line for 76. We've touched along on that sort of figure. Actually, if I present to you today, we're in Oakwood 4 and we've got 80 patients, so, and it has been as low as 100 last week. So again, that's variable in how we work with the system. Two other indicators which we don't often reference in the meeting quite so frequently, but our number of stranded and super stranded patients, and again, in month, in the end of February, at the end of March, was we had 263 patients over 7 days. That might be realistic and appropriate. We had 115 patients over 21 days, super stranded. If I talk to you today, just to give you those figures, there's 161 patients, so that number's come down significantly on the 7-day piece. We've actually gone up to 134 on the 21 super stranded patients. So our gridlock, or our ability to move and flow out of the hospital consistently to keep that escalation capacity to minimum, is not there. And as we've approached the beginning of May, we still have escalation capacity open. The hospital, as I just said, is on note for this morning. And we're definitely feeling pressures of the emergency care demand in the system. We had 309 attendances over the last 24 hours. Again, our performance, to be honest with the board, has come down significantly in the last week. We've withdrawn some of the additional investment we put in, and we obviously have approved through necessary governance channels in recent weeks investment into it, and I think that will make a step change improvement as we go forward. So I want to provide assurance there is a UEC improvement plan looking at that will be very much focusing on the subsets of indicators that we look at through here. And whilst on the surface they may look as if we're performing quite well on ambulance handovers against the national targets.
So I'm just struggling to compute everything.
Okay.
It might just be a key bullets.
Okay, yeah, all right. So UEC improvement plan is in place, and we will aim to improve that going forward. And this next week. From an elective care pathway position, we ended the year with forecasting to deliver less than 40 78-week breaches. We had 37, so we were online. Half of those were patient choice. There were people wanting to not have their operation before the end of the month. As we move forward into the next year, our target is to remove the 65-week patients, waiting on from that by September. That figure at the end of March was 936. With our current delivery forecast, we believe we will have a residual of 200 patients by September still on books in terms of 65-week. And I think it's worth pointing out to the board, we are an outlier with that number in these attracting some scrutiny on that. Diagnostic capacity, again, absolutely fundamental to cancer pathways. We're still struggling on our CT delivery and on our non-obstetric ultrasound, so that's down now 60% against an expectation of 85%. That moves to 95% next year. So again, we've got some real deficits to build in that one. Our cancer performance, I think, worth noting the 4 indicators that we regularly look at. We haven't closed down the end of the year quarter yet, but our February performance against the 2-week wait was almost on against target. Our issue there is on longer waiting patients on 62 days. Now, we came in on target where we anticipated we would end the year, which was forecast of 108 patients waiting 62 days. We actually had 111. That number has since escalated with the Easter and holiday absences. So again, difficult position to know in the 62-day issue, particular issues in our 470. Thank you, Ellen.
Is this the new performance report, the one that we briefly saw, because it looks like the old performance report?
So we haven't put in the background data, which is.
So we, it hasn't been produced, but I don't know what's on that.
So I think there's a lot we can do with this data to make it a lot more linking from initiatives that are happening in the hospital, which will not reiterate previous conversations about that. Just an observation for myself, something I would appreciate, and it might be this, it might be just a one-on-one. I think I would benefit from taking 45 minutes just to look at the longer term data and as we're setting budgets and targets for the new year ahead, so that I absolutely have it clear in my head where the issues are, so I can align them with the priorities that Joe's setting for us to spend money. And maybe the data's here, and maybe I can absorb it and be a bit lazy to ask for some help, but I would appreciate something that gets that in my seat as a skull, so I've really got it well summarised.
Really good point.
So two things on the back of what you just said. Firstly, from the urgent care side, we are just about holding our own, but we're under pressure. If you bear in mind, July is always our busiest month, then we have to find a way of making sure we've got some capacity coming into July, and we haven't. So July, we're just about holding our own, but our performance isn't very good. Nationally, comparatively, it's fine, but it's not very good where we'd like to be as an organisation. The figure that I think the board should really focus on is the 200 patients that we are at the moment saying we're going to have waiting more than 65 weeks in September. And that's an estimate because of things like urgent and cancer patients coming through that will bump some of those routine patients waiting. It's an estimate because we don't know how many patients we're going to cancel between now and September because of activity pressures. And it's an estimate because we aren't yet in a position to be able to plan perfectly exactly what's going to come up our theatres and the conversion rate between the day cases. So there's a high element of risk associated with that 200, as well as us being an outlier with the people. With people around the table saying, well, hang on a second, you get paid for every elective patient that you treat, so why don't you just get on with it and treat them all? Yes, absolutely. The and there is twofold again. One is there capacity within our organisation to do that? And can we do that at a cost that's appropriate? So not that's going to cause us a financial problem. So are we going to make any sort of margin on it or break even? And that's hard because the specialties, number of specialties that we're looking at are specialties that don't have capacity in the hospital. I think the second aspect is then also, how do we do that in the context of the NHS being asked not to increase its headcount? So you'll see in the stories in the HSJ and elsewhere, organisations being told to take hundreds of full-time equivalents out of their establishments. So we can't just go out and recruit loads more people. So we're trying to balance that at the moment. We're in May now. We've only got a few months to go, and that I think is the biggest risk at the moment for our organisation in terms of reputational.
Oh, so I was going to ask that question because hearing Emma and Gary raised really good points in terms of how we're going to cite ourselves on the future. But I might come back having heard what Emma said, particularly in the ongoing conversation there, that we know we've got a flow problem, but also that we are citing those people who are most at risk if they don't get treated, i.e. patient harm,
clinical aspects
of it.
Yeah.
And so whilst I hear the target for September that is required, I think it's how we get that balance, isn't it, of what we're really focusing on trying to achieve for patient care would be my perspective.
And absolutely right. And the management of risk of patients that are sitting at home waiting for a procedure versus those that are coming in through ED,
yes,
and those that are being flagged as urgent or 2-week waits is a continual issue, but not just for our organisation.
So one of the things with on my mind particularly is, as I've been showing the audience, is metrics that actually indicate where you are causing patient harm, as opposed to lead indicators, which are people are waiting for a long time. And I still haven't got a handle on that. So it could be that we have got a long waiting list, but we're not necessarily creating more patient harm. So I just put that out there, just so that we're aware there's a gap in the data that we actually look at. What we do is we effectively measure risk indicators, long waiting lists.
Can we leave that with the team, I think, to consider how that conversation will come back to board or taken through committees? But I think we're cited on the issue in the report and from the comments you raised, Joe. I think that's what's the question that we're asking that we want brought back, and where do we want it brought back to, is what I'm hearing.
So can I break it into two? Can I suggest that there has been a number of target changes between last year and this year, and therefore it would be appropriate to bring something back to a Trust Board seminar early on, so the next one potentially, to say, okay, this is what we're now aiming at, and get into the bit more of the 45-minute conversation around this is what's driving the performance, this is what's driving our risk or otherwise in terms of achieving those targets. So that's one question. I think there's a more sort of desktop exercise around how we evidence the harm that we are potentially doing to patients on our waiting lists, and that requires a bit more thought. We should take away, but the easy bit, if you like, is the performance bit at this stage.
That's not an armour, is it? No.
I think what you're saying is put it on the seminar agenda, because it's a point that's come up with audits. And I personally, my assessment would be it's got to be happening operationally. Somebody somewhere must be taking an operational view on it as to harm in the list, but it's from a governance, audit and risk perspective, perhaps we're not seeing it as clearly as we'd like to. So is that topic for discussion at seminar? I forget when it is.
Well, the next month is
June. Or is it something?
I'm slightly anxious that I'm slightly anxious we'll get into a series of governmental platitudes around, well, it's a clinical decision about how urgent a patient is, and if their urgency changes, they should go back to their GP and they'll get referred in as an urgent, and then we'll treat them sooner. And then the organisational platitude of, well, we have no connection with whether a patient dies at home and what they die of. That's out with our purview, and therefore who knew what was the matter with them. So I think it is a really challenging question to answer. And I think what I'm saying is getting a better handle on the performance and how the targets are being driven and the risks associated with those.
Let's get on with that.
Will potentially allow us some more informed, challenging questions around how our wage mix are made up and how we're managing those.
We will leave it with the executives to agree with committee chairs, etc., how that's reported back through, and we'll keep track of that, where that's going to come to board and seminars.
And in June, we'll do these are the new targets and this is where we think we are landing.
So possibly, just to reassure, at this time of year, we always, and it's already started, we started with what we've been looking, this is Mark 12, so it's appropriate to sort of finish what we started before Mark 1, which will be the next.
Yeah.
Or we'll always look at both new targets and new indicators that should better inform what's going on. I think there are quite a lot of changes this year. And so if we get a draft out soon, month one can then be a more meaningful experience.
So I'm going to move this on. I'm not depriving us of our break. Before
Are you?
No.
Okay.
But before we do the numbers, we'll put those in the room, can have a coffee and a break. Well, I've got the same. And those people at home have got 5 minutes. I think we'll take ourselves 5 minutes because we're slightly behind on time. Thank you. Right, let's have a break. It's gone down. There are chocolate.